what gets someone put on a ventilator? So, as usual, there's some terminology here. And I think you're going to recognize a lot of it, which is always nice. All right, so ventilation is simply the movement of air from the atmosphere, from the room, into the lungs, okay? But what's the most important part, or just as important part of ventilation? The ability to remove CO2 from the body. Okay? How do we quantify ventilation? How do we put a value to it? What's the term?
Minute ventilation?
Minute ventilation. Okay, you guys? You're gonna hear me say minute ventilation 1,000 times before you ever graduate from this program, because it's so important, okay? Now, how do we know if we don't have enough ventilation going on? ABGs, okay?
Ventilatory failures, pH is 7.25 and dropping, and it's CO2 of 15 rising.
Yes, okay? We know the patient isn't ventilating properly because we'll look at a blood gas, right? What are we gonna see on that blood gas? We're gonna see an elevated CO2 and a decreased pH. Okay? All right, this is a term you should recognize as well. Internal respiration. You can tell me what internal respiration is. I know it says right there, but I'd love to hear your voices. So what do we think? Internal respiration as opposed to external respiration.
Exchange of oxygen between tissues inside the body.
Versus, what's external?
Exchanging oxygen with the atmosphere.
In the alveoli, right? In the lung. Okay. So internal respiration. This is oxygen coming off of your hemoglobin and being taken in by the cells to be used to produce ATP and whatever else that cell is producing, okay? Now, again, internal respiration, it's not just oxygen going to the cells. What else is it?
CO2 being
CO2 coming out, okay? Now in 117, we talked about CO2 attaching to the red blood cells and coming back to the lung. But remember, as we got into 135, that's only a fraction of where that CO2 goes, okay? It's like 17% of the CO2 is taken back out through there. Where does the rest go? What happens to the rest of the CO2? Okay, tell me more.
That's why I want to say nothing. You don't know. Oh,
It binds to what?
the water.
Binds to water.
Becomes.
oh, the carbonic.
Becomes, yep, carbonic acid, okay? And is exhaled out of the body, okay, as CO2, or becomes bicarbonate, okay, if you need more bicarbonate. All right. Okay. So, respiratory insufficiency. Now, this is getting along the same lines as ventilatory failure, right? But we aren't saying ventilatory failure here. We're saying respiratory. So when you see respiratory, we're combining ventilation and oxygenation. Now, remember I told you guys that ABGs are always, there's two parts, right? We're assessing acid-base balance and we're addressing oxygenation status, right? So anytime you see the term respiratory, they're talking about both, okay? Where ventilatory failure, we're talking about only acid-base balance. Okay. So the condition in which the work of breathing required to allow the lungs to take in sufficient oxygen and or expel sufficient CO2 reaches a level that is unsustainable for an indefinite period of time. Okay. Now the maximum minute ventilation that can be sustained for an indefinite period of time in a healthy person is about 20 liters a minute. Okay. And that's a considerable amount of breathing. What is our normal minute ventilation? You guys got it. We'll spit it out at me.
5 to 6. Yeah, 10 minutes.
Perfect. Thank you, Nietzsche. Mickey.
Either one.
Okay. Perfect. 5 to 6 liters a minute. Okay. Now keep in mind that's someone at rest. Okay? That number increases dramatically as soon as you start doing some work. Okay. Respiratory failure. A condition in which the pulmonary system is no longer able to meet the metabolic demands. So we've gone from respiratory insufficiency, okay, to respiratory failure. What are some things that can cause this? We're gonna get into a bunch of them, right? What was one of the first things that comes to mind? What about lung disease? Okay. There's a whole smorgasbord of lung disease out there, right? Okay. Lung disease, and that's where our bread and butter is gonna come in as we learn about these separate lung diseases, okay? Now, in Professor Sabrin's classes last semester, you had what? You had a basic pharmacology class. Did you guys go into pathophys at all, like different lung diseases?
Yep.
Some, yeah, we did.
Some? Okay, all right.
COPD, asthma.
Okay, the basics, the basics. Okay, good, good. So all of those cause an increase in work of breathing. They do it through different mechanisms, but the overall effect is that you have an increased work of breathing. So what is the physiologic effect of that increased work of breathing? It takes a ton of energy to do what you and I are doing with very little energy, okay? And that is what causes the fatigue, the wear out that leads to respiratory failure or respiratory insufficiency, okay? At least when it comes to lung disease. You can absolutely go into respiratory failure by trauma, okay? Getting your circuit scrambled, okay? Of course, the omnipresent opiate overdose. Ugh, it's the worst. And a number of other things, okay? Go climb up on Mount Everest and take your oxygen mask off, okay? You're gonna have some respiratory insufficiency happening pretty quick. Yeah.
If someone has a minute ventilator, or if someone's breathing 20 liters a minute or over, instead of intubating them, can you put them on BiPAP?
You can, yes, you can attempt to assist them through various means,
Okay.
but that's gonna depend on the specifics of the patient. All right. So, respiratory failure. Again, we're saying respiratory, so we're talking about oxygenation and ventilation, right? Okay. We have acute respiratory failure. We have chronic respiratory failure. Now, when we were interpreting blood gases, we looked at the difference between these two, right? So what are we gonna see in an acute respiratory failure?
Uncompensated.
Uncompensated. I see you, Evan. I just gotta give everyone else a chance. I appreciate your enthusiasm there. Uncompensated, often respiratory acidosis, right? That means it's happened quickly. Did the kidneys react instantly? They take time, right? Okay. Chronic respiratory failure, what are we gonna see here? What's our blood gas gonna look like?
Compensated.
We're gonna be fully compensated, or at least partially compensated, right? Have our kidneys had time to correct the respiratory insufficiency? Yes, they have, okay? So you'll see elevated bicarbonate levels, elevated CO2 levels, but normal pH. And at the end of the day, the name of the game when it comes to acid-base balance is what? Normal pH, okay? Your body will do anything to make sure the pH is normal. Okay, so our definition of respiratory failure is, check it out, ventilatory failure plus failure of oxygenation. PaO2 of 60 millimeters of mercury on room air or less. Okay. So, 4 types of acute respiratory failure, okay? We're talking acute now, not chronic. You're gonna learn each type. Okay. So type 1 is hypoxemic respiratory failure. If you're thinking about a blood gas and you hear the term hypoxemic respiratory failure, what's that blood gas look like in your mind?
Acidotic.
Well, are we talking about pH at all? Are we talking about acid-base balance?
Lower than normal oxygen.
Low oxygen.
Decrease oxygen. Okay? So you can have someone in hypoxic failure with even keep it normal. Okay. What's the problem here? Okay. why is the pH running slightly acidotic, and why is the, or I guess the CO2 actually kind of have the other direction, but what's this person gonna be doing? Like, what's the patient gonna look like, a hypoxic patient?
Like they've been
I
physically exerted or something, or, you know, they're gonna have to get
Right, like this, sorry. I mean, you did say it, they're gonna be tachypnic, right? Okay. The patient is going to be breathing more quickly than they normally would as a compensatory mechanism to compensate for this low oxygen. Okay? The respiratory centers in the brain are saying, not enough oxygen in the blood, breathe faster, get more oxygen into the lungs. Okay? What else is gonna happen? You're gonna breathe faster, what's the second thing that happens almost simultaneously?
increased
Heart rate, yeah.
Heart rate increases, okay? Not enough oxygen in the blood, no problem, I'll move more blood. Okay, then we have type 2, hypercapnic. The term hypercapnic, what does that mean? Increase CO2, good. So type 1, not enough oxygen. Type 2, hypercapnic, ventilatory failure. Yes,
Okay, can you tell me the difference between a respiratory insufficiency and respiratory failure?
say it a little louder, I can't hear you.
Can you tell me the difference between a respiratory insufficiency, because you said the respiratory failure was oxygenation and ventilation. What did you say the insufficiency was?
Respiratory insufficiency is leading up to the point of failure, okay? So it's increased work of breathing that is unsustainable. So the person will be able to, for a period of time, compensate for that work of breathing, but they're going to exhaust. And when they exhaust, they will go straight into respiratory failure.
Okay.
Okay, type 3 perioperative respiratory failure, and you guys, we're gonna look at all these a little bit closer, okay? This is just the rundown. Usually atelectasis or pneumonia after some kind of medical procedure. Okay. How many of you in your clinical site have gone out and done IS rounds? Why do almost all these people have ISs? To prevent atelectasis, reduce the chance of pneumonia. And even if the IS, you know, the research says it doesn't really do a whole lot, okay? It means a respiratory therapist is going in and putting eyes on this person. Okay, and that's why I tell you guys, even the mundane tasks that we do as respiratory therapists, never take it lightly. Okay, because if you as a respiratory therapist go in and put eyes on someone, whether you're doing an IS or anything else, you're also looking at what? You're looking at that patient's condition, their respiratory status, right? So you can catch things. And type 4 is shock, okay? So this is gonna be circulatory failure. Okay? Usually, although it's not technically correct, but shock is usually defined as a loss of blood pressure leading to end organ dysfunction. And the first type of end organ dysfunction you usually see is altered mental status. Yes,
What are normal causes of shock?
there's quite a few.
Okay.
Yep. I don't know if we go into it in this slide, but we will, okay? So there's the most common thing you're gonna see is distributive shock, which is sepsis. Have you guys dealt with sepsis yet in clinical? You're gonna see sepsis patients all the time. Super dangerous, kills tens of thousands of people every year, but that's the most common type of shock that you're gonna see, okay? Plenty of grandmas and grandpas been taken out by a UTI, which turns into sepsis and causes shock, distributive shock. But there's also, what is it, like cardiovascular shock where the pump itself fails. There's hypovolemic shock, you bleed to death, okay? All right, so let's talk about type 1 hypoxemic respiratory failure. It's simply a PaO2 of less than 60 millimeters of mercury on room air. What is our normal patient's oxygen saturation at a PaO2 of 60?
90.
90. Yeah. I like how you said it like it's just like, well, yeah, it's 90. That's perfect, that's what I want, okay? That's what I want to be in your head. Okay, and how does this happen? So, four most common causes of hypoxemia, right here, okay? Now, there is one that's left off of here, okay? And that's hypoxemic hypoxemia. But you just don't see it a lot because guess what? We live close to sea level, okay? Now, if we were respiratory therapists up on Mount Everest, you'd see this all the time, right? Because it simply means that you're in an environment that's low on oxygen. If there's no oxygen in the room air to breathe in, guess what? You're gonna be hypoxic. So, VQ mismatch, shunting, diffusion limitation, and alveolar hypoventilation. All three of these things are actually kind of part of VQ mismatch. And we're gonna get in this. Okay, we're gonna talk about VQ mismatch quite a bit here. I gotta make sure that we don't run out of time though. How many people have watched the videos that I have attached to this unit? I recommend you guys watch these even before the lecture. Okay, they're actually quite entertaining and they're gonna give you a clue as to what we're talking about. That way you're being introduced to it at the very beginning. I mean, I get it when it's wrong last night, okay? But they're there for you. All right, so let's talk about VQ mismatch. All right. So, we've got a couple different pretty important organs. So, you're looking at this person like this, okay? So this is the right side, and this is the left side. Over on the right side, we have the right heart, okay? I'm gonna draw it like this, just because. And over here, we have the left heart. Sorry, by adding that line, it makes it not look like a heart at all. Where is the right heart sending blood? To the lungs, right? Okay. Where is the blood coming from that goes to the left heart? Where's that blood come from? Comes out of the lungs. And where does it go?
So the rest of the body.
Goes out to the body. Goes out to your systemic circulation, right? Okay. What VQ mismatch is when there is a difference between the amount of blood that should be going through the lungs and the amount of ventilation that's going into the lungs. So VQ literally means ventilation perfusion. Okay? VQ equals ventilation over perfusion. Okay. And VQ mismatch is when there's either excess ventilation or excess perfusion. Okay. When we think of perfusion, what are we thinking?
Blood.
Blood. Okay, perfusion always equals blood flow. Now, ventilation, what are we thinking? We're thinking, yep, the lungs, the ability to bring air in and out, okay? Lungs, and I'm gonna put minute ventilation, oops, like that. Okay. So if you think about it, normal cardiac output is what, 4 to 8 liters a minute, okay? Normal minute ventilation is what?
5 to 6 liters.
5 to 6 liters a minute, okay? So let's say we're gonna do our normal cardiac output, Q, always on the bottom, perfusion, we'll say is 5, okay? Normal minute ventilation, 5 to 6, ventilation on top, we'll say 5, okay? 5 divided by 5 equals what? 1, okay? This means normal ventilation to perfusion ratio, 1.
So it's a 1-to-1 ratio for the most part.
What's the normal, cardiac output?
4 to 8 liters a minute. But understand that I am arbitrarily choosing these numbers. Look, I can just pull a number out of my butt. 28 over 28 equals what? 1. Okay, there's no actual value to these numbers I'm putting up here. The actual cardiac output doesn't mean anything right now, okay? The actual minute ventilation doesn't mean anything. I'm just arbitrarily assigning numbers. Yes?
Is it okay if you're at rest, breathing 6 liters a minute, and your cardiac output is 4 liters, or 4, what is it? Liters a minute?
4 to 8. Yeah, probably.
Okay.
All right, but usually there's a close relationship, okay? So, our normal VQ ratio equals 1. Okay. Now the slide is gonna say, no, normal is 0.8, okay? Just ignore that. Okay. Yeah, it's technically accurate, but guess what, on your board exams, the only thing they're gonna ask you is if you have a high or a low VQ ratio, and we're gonna talk about that right now, okay? Okay. So, let's see, I need more room, I write too big. Now, there was a term on the previous slide, or a couple of them, okay? Shunt, okay, shunting. So, what's that mean? What's a shunt? A shunt is when you have more perfusion than you have ventilation, okay? So perfusion is, great, hold on, I'm going like, freaking, not gonna say it. Other way, right? Perfusion is greater than ventilation. Okay. So if we go over here and we'll just arbitrarily say our heart is putting out 5 liters of blood a minute, and we'll say our minute ventilation is 5 liters a minute. Do we have more perfusion than ventilation? No, they're equal, right? They're 5 over 5, they're 1. Okay. What could cause us to have more perfusion than ventilation over here? Everything's normal right now. What can change that? To where blood flow stays normal, but ventilation decreases.
I was gonna, well, you could increase blood flow and have ventilation stay the same too, right?
You could.
Yeah, so like nitric.
Okay.
Yeah.
Okay. Going deep with it right off the bat. What are some things? What about that IS? About that post-op patient?
Shallow breathing.
Shallow breathing causes what? Atelectasis. Okay. So we developed some atelectasis down here in the bases. Someone tell me what's atelectasis? What is it?
Collapsing of the
Collapsed
alveoli.
alveoli. Okay. So you've got an atelectatic, which is a word, cool. Alveoli. Okay. Shrivel a little bit. Do we still have proper blood flow going past it?
Yeah.
Yeah. The blood vessel didn't collapse. Okay. So we've lost ventilation, but our perfusion has stayed the same. And so here's what VQ mismatch questions are gonna look like, okay? A patient has a VQ scan that shows decreased ventilation in the left upper lobe, but normal perfusion. What could be their VQ ratio? Okay? And I tell you what, it's easy. So look, V is always over Q. Okay, normally, we match, right, to equal 1. So in this case, the question itself said decreased ventilation. So let's just arbitrarily assign a number, okay? Normal perfusion, so we'll assign a higher number for perfusion. What's 2.5 divided by 5? 0.5. Is 0.5 less than 1?
Yes.
You have a low DQ ratio. Okay. You can't overthink VQ mismatching. Okay? You just make things more difficult on yourself. Okay, so over here we have a shunt where we have perfusion is greater than ventilation. Don't worry, we'll go back over this, okay? What else can cause perfusion to be greater than ventilation? So we have atelectasis. What else?
Decreased respiratory drive.
Decreased respiratory drive. What else?
Nitric oxide.
What else? How about
Collapsed lung.
pneumothorax? You guys are missing the most common one.
Lobectomy.
Get out of here. No, they cut the blood vessels out too when they take the lobe.
Oh, okay, thank you.
Pneumonia.
Plural.
Pneumonia. Pleural effusion causing atelectasis as well. Pneumonia and pulmonary infiltrates, consolidation, okay? Kind of like pleural effusion. Okay. All right. And so this is called shunt. All right? Perfusion equals ventilation. If I walk up to you and say, hey, what's a shunt? I want you to say perfusion is greater than ventilation. Yes?
I thought shunting was like when like deoxygenated blood flows where
Yep,
oxygenated blood
that's an
flows.
anatomical shunt.
Oh, so, okay, that's different.
Yep. So, in that regard, it's kind of the same thing because blood's not getting oxygenated. Okay? It's kind of similar here too. Blood's going through the lung but not getting oxygenated because there's a defect in ventilation.
Okay.
Okay? You're absolutely correct. Okay? That is absolutely a shunt. It's anatomical shunt. Okay? We're talking about pulmonary shunting right now.
Okay. Sweet.
All right, and then on the other side here, we have dead space. And this is the opposite of perfusion greater than ventilation. This is ventilation is greater than perfusion. Okay, so what's that mean? It means we're moving air in and out of the lungs, but there's something wrong with our blood flow. Now, can we think of disease, syndrome, issue that can cause this? Yep,
Heart attack.
heart attack. Okay, so cardiac failure, or I'll say decreased cardiac output. What else? I just don't know if you guys have gone over this stuff with Professor Saber.
Trauma.
What's that?
Trauma.
Trauma, okay, yeah, so shock. There's two key ones that you're gonna see more often than others.
DK.
To a point. Okay, what I'm looking for is pulmonary embolism. Okay, pulmonary embolism. Does anyone know what that is? You guys probably haven't gone over in class yet.
It's a blood clot in the lungs, right?
It's a blood clot in the vasculature that leads to the lungs. Okay? So it's literally a blood clot. Okay? Blood cannot get past here, therefore it cannot oxygenate even if that alveoli is fully functional. Okay? Yes.
How does that increase ventilation?
Because you can
Because-
still breathe, you just can't
Yeah.
oxygenate.
Because
Oh.
ventilation's normal, okay,
Oh, but it decreases perfusion.
but it decreases
Ah,
perfusion.
okay, yeah,
That's
yeah.
exactly right.
Okay.
And the second one I'm looking for is COPD. Okay. COPD, air trapping. All these alveoli are fully blown up, but there's massive destruction of the vascular bed. Okay? So you end up with increased dead space. Okay? And do we remember what dead space is?
Parts
With no gas exchange.
Airways.
No gas exchange.
No gas.
Yep, airway's one of them. Air goes through it. Air's in it. Air enters it, but does not participate in gas exchange. So think about it. Air's moving into this alveoli. Y'all are thinking it. I'm not gonna say it out loud. Okay, everything's cool, right? Everything's good. We got blood flowing through here. We've got air coming into this alveoli. Okay, everything's normal. We're 1-to-1 right now. Okay. Uh-oh, big old blood clot flows through here. Blood flow ceases. Are we still ventilating? Ventilation, yeah, we're ventilating. Ventilation is normal. Blood flow has stopped, so there's no gas exchange taking place. So we have increased our dead space. Okay. All right. So here we have an example of ventilation being reduced, right? Okay. Now, remember, it's always ventilation over perfusion. Okay. So let's say a question, I don't know, I'm just gonna pull one out of the air. A patient suffering from a pulmonary embolism will have a high, low, or normal VQ ratio. Just write it out, okay? Ventilation. Remember, it said pulmonary embolism. We know that that's on the dead space side, so we know that's perfusion. It didn't say anything about ventilation, okay? So we'll just arbitrarily assign a number to ventilation. What number do you want?
5.
You want 5? Okay, 5. Now we know pulmonary embolism, okay, like I just said, affects perfusion, which is the Q. So we're just going to assign a lower number. Doesn't matter which one. 4. What's 5 divided by 4?
It's higher than 1.
1 point something.
1.25.
1.25. Is 1.25 greater than 1? You have a high VQ mismatch. Okay? So that's what VQ mismatching is. In the contents tab under this unit, I have a really great video that Respiratory Coach did on this exact same thing. I recommend watching all of them that I have on there, okay? But this is VQ mismatching. Does that make sense, or is I just got everyone kind of confused? Okay. It's just the relationship between ventilation and blood flow. Okay. Different diseases, different situations affect either ventilation or blood flow. Okay, so VQ mismatch is the most common cause of hypoxemia, okay? There's either not enough ventilation or there's not enough blood flow. Do you see how either one of these, the end result will be decreased overall oxygen content? Okay. Yes?
Is methemoglobin VQ mismatch?
That's a great question. Yeah,
Yeah.
yeah. It's kind of its own little special side thing of it, but sure,
Okay.
yeah. I mean, I guess that'd be more under diffusion limitation,
Okay.
but,
Well, the blood's flowing and the ventilation's happening, but it's just not binding to the hemoglobin.
right,
Yeah.
yeah, so I'm thinking more diffusion limitation on that. Oops, wrong way. Okay. So a low ventilation is gonna end up with a less than 1 for your VQ ratio, okay? So you're gonna end up with a low VQ mismatch. Decreased perfusion is always gonna be a high VQ mismatch. Okay. Do you want me to go over again how to determine high from low? What's that? No? Yeah? Okay, let's do it one more time. I'm gonna erase this. Then we'll take a short break. Okay, so let's see, I have a couple example questions that I'll reuse that too. Okay, well. What effect will a patient with a pneumonia, what effect will a pneumonia have on a patient's VQ ratio? That was the question, okay? So V over Q, every time. You even say it in the right order, VQ. Pneumonia. We are on the ventilation side, right? On the shunt side. Perfusion greater than ventilation, okay? So automatically we know ventilation is the part that's affected. We're going to assign it the higher or lower number?
Low.
The lower number, okay? Whatever side's got something wrong with it, give it the low number. Okay? And let's just choose a number. I don't care what it is, choose a number. 4. 4. Okay. Now, in that question I gave you guys, did I say anything about perfusion? Did I say anything about pulmonary embolism, COPD, or decreased cardiac output? No. So we assume it to be normal. Okay? Don't make things up that aren't in the question. Okay? So perfusion, we're going to assume to be normal. So we're going to give it the high number. What number you want?
6.
6. What's 4 divided by 6?
Less than 1.
0.66. 0.66. Is that greater than or lesser than less than 1?
Less than 1.
It's less than. Low VQ ratio. Look, pneumonia, right? Low ventilation, low VQ. Now, what if they gave you some possible answers? Okay? What if in the question I said, okay, what effect will a pneumonia have on a patient's VQ mismatch? And I gave you possible answers. I said 1, 4, I don't know, 8, or 0.8.
Be 0.8.
We know 1's normal, right? Okay. We know that 4 and 8 is a high VQ mismatch.
No.
Okay? And if we arbitrarily assign numbers, we'll get less than 1, right? So even though I gave you no numbers, you know that the answer has to be less than 1. Okay? They aren't going to give you any numbers in the question either, because guess what? The numbers don't mean anything. They're arbitrarily assigned. Okay? The point is, you either have a high or a low mismatch. Yes?
If ventilation's affected, it's always lower than 1. If perfusion's affected, it's always higher than 1.
There it is.
Okay.
Yep. So that's VQ mismatching. Guess what? There's entire books written on VQ mismatching, okay? We can go way down the rabbit hole with this. Okay? We absolutely can, but we're not going to. Okay? I'm like 99% sure you're gonna hit it again next semester with Professor Sabrin, so I wanted to spend a little extra time on it right now with you guys, okay? Kind of plant that seed, hopefully.
What did you say, Evan?
If ventilation's affected, it's always lower than 1. If it's perfusion's affected, it's always higher than 1.
There it is, right there. But either way, whether it's a high or a low mismatch, the end result is decreased arterial oxygen content. And that's why we're talking about it now, when we're talking about hypoxemic failure, okay? Let's take a quick break and get back to it. Let's do like a 5-minute break, because we really gotta get through